or equine Ehrlichia abortion is another name. And you probably remember that mares can develop neurorickettsiosis, and they will recover from it, but they will have abortions that usually happen between 90 and 150 days post-infection. Now, a little bit of history. Perhaps some of you in the audience that have been at OVC or are graduates from OVC have seen this picture in the old pathobiology, or now in the new pathobiology, Dr. Frank Scofield, which was an OVC grad, immigrated from England, and became a vet at the Ontario Veterinary College, and then become faculty afterwards. He actually has a wonderful account or investigation in 1924 of some diarrhea outbreaks in Western Ontario around Lake Sinclair, and I'll show you a picture of that. Dr. Scofield actually performed a fantastic investigation where the farmers told them already that this disease happened usually in the summer. They already said that probably was associated with the migration or with the search of insects from out of the lake, mayflies to be precise. He already did challenge with mayflies to horses and to rabbits, and actually cause disease in rabbits. And he could also cause disease by giving blood from one horse to another, but not by oral infection. So he couldn't figure it out. He couldn't detect the organisms at that time, but he was describing very much like was an outbreak of Potomac or cases of Potomac. And if you can see my arrow here, you can see here. So this is Lake Sinclair, and this is Wallaceburg, and all these dots there where the cases were described. You see how close to the water they are. That is in Harrow and Amherstburg and all this area, Tilbury. That's where all the cases were happening. And nowadays also we have cases from this region. Next slide, please. So here I give a little bit of a history of what we know about this disease, which I think is fantastic. As I mentioned, we are fairly confident that what Dr. Scofield described in 1925 was this outbreak that he basically 1924, published in 1925, was a Potomac Horse Fever or neurorickettsiosis. Now in 1979, that's when, as you know, all these cases happen around in Virginia, close to the Potomac River. And that's when for the first time, this group in Illinois that were working with rickettsia organisms managed to isolate these Ehrlichia organisms at that time in cell cultures. What about Canada? So actually, Dr. Ristic did a serological studies, and there is a beautiful table where he had blood or serum from many states in the United States, and then from actually Saskatchewan and Ontario, and he had 6 blood samples from Ontario horses, and 2 of them were positive. So this is the first time that we have at least some evidence of serological exposure to these organisms in Ontario. And then more convincingly, also, Alberta already in 1989 described several cases. This is serological testing of, I believe, 10 cases by Dr. Pritchard. And then she described, these cases around the Red Deer area. And then a little bit north of Edmonton, Dr. Jones in Sanguro, to be precise, he described 2 horses with swollen limbs, so limb edema, and they were positive serological for Potomac Horse Fever. Then in Ontario, they already in their paper, they already said that Ontario very much was a confirmed situation. But Dr. Shapiro and Thompson here at OVC describe cases in Eastern Ontario, and then Dr. McLaughlin and Go describe cases in Southwestern Ontario, 95 and 96 respectively. Furthermore, in 2004, Dr. Heller described 2 cases in Nova Scotia, and she was a resident in Davis, so she took some paraffin bev tissue, and they confirmed this by PCR in Davis. And then there is a case report for 1 case of a case from Manitoba that was referred to the Western College of Veterinary Medicine, and that was also positive for Potomac at that time. And then lastly, we just this past year We are going to talk about today about a new species of rickettsia that is capable of causing what we call Potomac Horse Fever. And that's some cases that we collected blood in 2016 and in 2017. So just a little bit of a graphical representation here. Ontario, 1924, and then 86, that Diagnostic again in Ontario, and then 89 and 90, that will be Alberta, and then so on, as you know, 95, 96, again, Eastern and Western Ontario, and then in 2000, Dr. Heller and the Maritimes, and then in 2016, that's from Manitoba, and this is also in 2016, we published the first isolate of Rickettsia rickettsia here in the Great Toronto area. So in that year, we had a case, and for the first time, we have the first Canadian Rickettsia rickettsia isolate from the province of Ontario described and compared to isolate from the United States. And then in 2020, we have our new species. Now, this is a global distribution and a little bit of a more broader view of the world. So this is a disease very much confirmed for decades in North America. So as you know, I think over 40 plus states in the United States have been confirmed. And then in Canada, we already have several provinces confirmed as well. Brazil and Uruguay, again, and then Argentina, they have identified Rickettsia rickettsia in bats as part of the life cycle, as you will see later, for those of you that, you will see. And there also serological evidence, or at least there were some case reports from France and in the Netherlands. So we don't know much about it. They were very far back. We don't have a lot of details on these cases, but at least they claim that they tested positive. There is also, we have a friend in Georgia where he travels the world testing for parasites, and he has described some rickettsia in the Philippines. And I did went for a different reason to the Philippines for some outreach purposes, and I did see some horses very sick, and we are very interested to see if this disease could be present in other parts of the world, because all the perfect conditions are there to happen. And actually other types of similar diseases, for example, other rickettsias that can cause disease in humans are present, for example, in Japan. Next slide. So now back home, this is actually a study that is coming out next month on CBJ. And this is a little bit of data that we have been collecting, not only for clinical cases, but also cases that we have been culturing in the province. So basically, these dots here represent confirmation of rickettsia in horses by either culture and blood, for example, or PCR in feces and blood, or PCR and blood, feces, and culture, etc. And I guess, you can, I'm sure, read the publication next month, but you can see that this disease very much distributed all along southern Ontario. I want to call your attention that this is one of the farther north cases. I know that this is northern, but in terms of straight up here from Guelph, this is one in the Midlands. This is one of the cases that we culture one horse, and it's been the farther up that we have seen it. Around Lake Simcoe is highly prevalent. We have a lot of cases, some clinical practices in this area. And the horseshoe area here around Hamilton, Ontario is, we have a lot of cases in this region. And there are some hotspots, some river like the Grand River, etc., where we see cases. And back to Lake Sinclair, just for those using the arrow depth, thank you. Here in Lake Sinclair, where that's what Dr. Schofield, no, that's Sinclair Western.
Sorry, here.
And that's what Dr. Schofield described the first cases in 1920. You can see almost these dots match Dr. Schofield's cases. And some of these blue cases here are culture cases that, the new isolates and that we will describe later on. And in this paper, we also describe, all the signalement and epidemiological data associated with those cases. What about, as you were taught in vet school, and rightly so, it's a seasonal disease, but maybe we should get a little bit broader. We used to think that it was very much a summer, and that's what make it like bold and large in the text here, because yes, the bulk of the cases are in the summer. However, we have cases as early as May. You can see this is data from last year. May 21st was the first confirmed case in Ontario. And our last case last year was actually on November 5th, something that we in the past never, at least used to believe that was happening. And we checked with our partners in Ohio, and the last case they have was actually on October 30th. And from Alberta, we should have a great partnership right now with Ashley and Moore Equine. We saw cases, usually in the summer, but we see cases late in the fall as well. Same from Quebec. We had a blood sample that Dr. Mathilde Leclerc sent to us, and that was, she actually rightly so mentioned that they see cases late in the fall, and we actually isolated the bacteria from one of her cases late October, if I believe, in this particular case from Quebec. So this is just a little bit of a graphical representation of the 26 cases confirmed for us by PCR in 2020, last year. Obviously last year, you can see the first case was already in May, and then it starts to climb in June. But for us, always the peak, typically almost 80% of our cases happen in July and August. But again, they can also spread out through some of the fall months. Next slide, please. Thank you.
All right, so I'm going to start talking about some of the clinical signs with Potomac horse fever, but I think we should kind of take a more global look at our diarrheas. And when you look in the literature, we really still have that same, even though our testings have improved, our procedures, we still have less than 40% of cases that get a diagnosis. And I think for those areas such as what we have in Canada that have Potomac horse fever, the majority of those cases that we do diagnose are usually related to Potomac horse fever here. Any of our inflammatory conditions in the GI tract could be obviously causing our diarrhea. And with Potomac horse fever, we tend to see mostly in the cecum and the colon, but you can also see with the small colon or small intestine as well. Although if it's just small intestine, we know we don't tend to see the diarrhea side of things with it. You can get that dysmotility as well, and water changes and secretion. So all of those different factors are going to be playing into our clinical signs of diarrhea. And if only a small portion of our large colon is affected by the Potomac horse fever, we're not going to see that diarrhea. And as we go through the percentages, you'll see that there is a fair number of cases that don't present with diarrhea and in fact have Potomac horse fever attributable disease. Endotoxemia, or that SIRS situation, is definitely a huge risk factor for mortality in these cases, laminitis being a very major side of it, and then our protein loss and electrolytes, which will definitely be a part of when we're trying to treat them. So really, we have considerable variation in the clinical signs with Potomac horse fever. The most of the cases are actually mild or subclinical, and so probably are never treated, are never identified. This may be a horse that's out in the field and we don't notice this. So they can be fairly healthy, no history of illness. And we are seeing in some of these horses that they do get a transient low antibody titer when we're doing serological surveys. Obviously, we're not testing these horses normally because they're not showing any clinical signs. And we don't know whether they're getting repeated exposure to sub-infections that's creating those low antibody titers, or if there's cross reactions to other rickettsii that could be contributing to those titers with them. When we look at the numbers from the literature, 90% of our cases seem to have this depression and anorexia off feed. So our ADR horses, and really that's where their mild signs can come into it. We do get fever in a fair number of those, and it's transient and about 3 to 7 days, depending on the the horse, and you may get a second fever. So it can be actually biphasic, which is more persistent, and it may be with that second fever that we start to recognize that there's a case or something going on at that point. We get ileus in quite a few of those cases, which is contrary to what we normally think about with our diarrhea cases having hypermotility, but actually having decreased gut motility with many of them. And then only 60% have that diarrhea, and we tend to think of that as our cue to start to test for this, which I think we're hoping people will think about all the other manifestations of this disease. And we can have something from very soft manure to that projecting pipe stream diarrhea that's basically covering everything. And that diarrhea can last anywhere from 1 to 10 days. And with natural resolution, even without treatment, that's kind of the time frame on it. So there is definitely horses that without antibiotic treatment can recover from this. Now, laminitis is seen in about a quarter of the cases, and what's really hard is those cases that don't show any diarrhea or other clinical signs and just laminitis. And we're dealing with the summer when we're thinking, is it pasture associated? Is it endocrine related? So it should be on your mind for a horse that may not have those other risk factors for laminitis if they come up with it. And as Memo mentioned earlier, the abortion is infrequent, but is reported, and it is delayed out after the mare has had clinical disease of some sort. So you get your pregnant mare having disease. It causes the rickettsia, crosses the placenta, and then can infect the unborn fetus at that point. And we get our abortion, and there are microscopic lesions that we can see on postmortem, and another good reason for submitting fetal tissues for a postmortem for those microscopic lesions. And we had one of those actually this winter here at our diagnostic services unit. And of course, just like anything with horses, we can see colic as our primary sign, since it seems to be every disease can result in a colic. So for our life cycle, we all remember these images from going through vet school and trying to remember metacercaria and all of the little flukes and such. But in general, we just have to think about that we have always a mollusk as an intermediate host. And it's not usually the way that the horses are ingesting. I always thought horses don't like escargot. Why are they eating the snails out in these aquatic areas? And as Memo said, it was recently when UC Davis published some information on that second intermediate host being our mayflies and our caddis flies, the definitive host being the flukes that come from those into things like bats or other aquatic area rodents, and our horse being a dead end host for these intermediate hosts that are going through. So they really are an accidental host in these, and it's usually accidental ingestion. So horses are accidentally, I have a picture here of the mayflies and caddis flies, and most yards have some kind of lights or barns which attracts these animals in the evening, in which case they die and fall down into either water sources, feed buckets, hay, other inadvertent ingestion by these horses. There was recently a paper by Madigan and Pastorella in 2020, which looked at injection of snails and actually horses standing in water that is infected and whether the horses could get infected. And they were not infected by standing in the water, but they do have to have that ingestion of those intermediate hosts. So whether it's through the water or the actual consumption of them while they're eating other items. So when we're thinking about when we're going to test, we first have to take a step back and know a little bit about the kind of shedding patterns, as well as the neorickettsemia when it's in the blood, for thinking about when's our best time for sampling these horses. So the bacteria multiplies within monocytes, macrophages, mast cells, and epithelial cells. Remember, it is intracellular. And it has, on average, if we were to put it, an incubation period of about 10 to 20 days post-infection. And you'll see at the bottom the study here that looked at it, and the blood detection is going to be a few days earlier than the feces detection of it. And that's where it's immediately into the bloodstream, and then we're going to get into the epithelial cells, and then in the colon, and then we're going to get into the feces. Also included here is a table from the paper that Memo was discussing that's coming out next month. And you can see they've here looked at the detection time by PCR in blood and fecal samples of experimentally infected horses. And so this gives us an exact timeline on it. And you can see that some horses actually had PCR positive within 1 day. So we do have a lot of variance there, but it again is similar to around that 10-day period for most of the horses, with the last day in the blood being kind of that 20 to 30 days out, and feces being a little bit more delayed behind the blood in with being positive on PCR. So our diagnostic tests for this, as we've mentioned, are real-time PCR, ideally doing that feces and whole blood because of that kinetics of it being in the blood first and feces, and us not knowing exactly when these horses were infected. You can do post-mortem samples of GI tract because of being within those enterocytes. And then, as I mentioned before, aborted fetal tissues, we can do either looking at histology or doing PCR of those tissues to look for it. We can also do paired sera testing, so looking at serum. There is some ELISAs, although most of it is done through indirect fluorescent antibody testing. And it's really important that we have those two time points of it, so that we can see that titer increase, because there is quite a bit of exposure, which we'll talk a bit about later on. And then we can do the isolation and culture. However, it takes quite a long time. And as we said earlier, Ohio is the only place that's doing that in a non-commercial fashion. But what that has allowed us to do is identify those new species and see their distribution, but also strains. Memo, I feel like I'm talking for a long time. Am I supposed to keep going here? I've lost my track.
I think you're running the show.
I'm good. Now. I am. I'm taking over. Did you want to talk here, or do you want me to keep going for a couple of slides?
No, carry on. For you have a few slides to go. That's fine. No problem.
Okay. So as I mentioned before, that IFA test is going to give us prior exposure, which doesn't necessarily signify the active infection, and it cannot differentiate between natural exposure and vaccine-induced titers. So that is really important, because we do have a lot of areas that are vaccinating for this. And really, when we're looking at any of these tests, so whether it's PCR or our sera testing, we really have to think about what makes the ideal test. And this is something that I've been pretty, I guess, an advocate for, is thinking about our diarrhea testing that we have, because we tend to send this shotgun approach. And so what really makes that ideal test for us is something that's accurate as well as precise. And some really great information, because we don't know what many of the sensitivities and specificities are on these testing, especially commercial testing, is we're starting to get more of this information. And I really like this slide from that same paper, which looks at two different laboratories and when the samples were submitted in parallel to Lab A and Lab B for both blood and feces, you can see that the feces actually correlates quite well between the two, whereas the blood only has a fair agreement on it. And so we don't have these perfect tests, and we're going to have a lot of false negatives in most cases, especially related to diarrhea. So I always look towards the human side of things as how are they doing it and what are they recommending. And a couple years ago, there was actually this guidelines that came out for the infectious disease on practices in diagnosis management of infectious diarrhea in humans. And they said that, you know, just like us, determination of the cause of the diarrhea is not always necessary. But when it is important to sample is when there's a high risk of severe illness, which most of our colitis can be, but more importantly, especially related to Potomac horse fever, where the ID of the pathogen would be important for the patient or for public health. So if we think of Potomac horse fever, we have a really good treatment for it. And so knowing that it's there then provides something very important to our patient. So when we look at this in general, overall, if it's going to change our treatment plans, it may be worth the financial input of the owner for sending that in. Determining anticipated complications, which there are significant complications that we can arise with ongoing colitis. Of course, all of our SIRS, sepsis, laminitis, especially with the laminitis with Potomac horse fever. Determining prognosis. Owners sometimes just want to know exactly what it is. And then we get into the isolation requirements and concerns for other animals. And we know that Potomac horse fever itself is not contagious between horses, but we also know that once you disrupt that microflora within the GI tract, you're more likely to get other pathogens that can come along that may be infectious to other animals as well. And so there is this obviously cost benefit because these tests are not cheap. If you do decide to do the testing, then it comes to bringing the information like we just talked about in terms of the life cycle and the shedding patterns to do your best practices. And that's why doing blood and feces at the same time, we might improve our options for diagnosing this. And then it's also about making sure that we collect enough, and you actually have to, you know, they have a guideline usually on there, but you really do sometimes, you know, a swab is collected and that's not going to be as sensitive once you start that testing. So actually collecting sufficient quantity. If you're worried at all about salmonella, utilizing the appropriate container with media in it. And then handling and shipping really becomes a concern, especially around freezing. So for Potomac horse fever itself, if we're just going to be doing feces, then looking at it in terms of the fecal PCR is during that soft to diarrheal phase. If they have that, is going to be obviously the most important time prior to antibiotic treatment, because the antibiotic will change the shedding drastically quite quickly within 24 hours. And so collecting that sample before that first dose of antibiotic will be important. And then storing it in a fridge around 4 degrees and preventing it from freezing, because that will change the test on there. So that leads us into some very good testing has gone on and the new bacteria.
Yeah, and maybe just to emphasize a little bit about the PCR, I think that obviously some differences in with some testing would be many things related to the lab practice, you know, from DNA extraction to the PCR, you know, conditions, etc. For the most part, we're talking about real-time PCR, but we also do nested PCR, which is more sensitive. And perhaps some of the difference that you saw in the experimental studies about the detection rate in these different stages had to do with that. So if you look at some of the ones that are detected about a week or so in feces and blood, they usually were talking about real-time PCR. Nested PCR, you know, can pick up very little amounts of DNA. So that's why we increase the sensitivity. Now, let's jump straight into this. This past year, this paper came out where described a new species of Neorickettsia that we're gonna call it Neorickettsia finlensis. So you already saw the name before. I'll give you a little bit of background about all this. Let me pedal back a little bit, and for those there, to let you know that Dr. Ricky Hisa already had very strong evidence, and she was working really hard to, this is not new. She already was, working in some isolates that they were not typical Neorickettsia, and they thought that could be a new species. And I'm gonna call your attention here to this table when you can see Neorickettsia species 081. This is an isolate that she isolated for Finley, Ontario, in the early 90s, and she thought that that was gonna be a new species. She unfortunately lost that isolate in one lab error where the liquid nitrogen dry in the tank, and then she couldn't do any further testing. And she must be, going completely crazy when we sent a blood sample from 2 horses from Ontario in 2016 and 2017. This finish in 2017, horses referred to us by great practitioners in Western Ontario, Dr. Donovan and some other people, and on a horse in 2016. And they were not, these horses, when they do all the molecular testing, they were not Neorickettsia ristisi. And this phylogenetic tree, just to highlight, for example, here, they are quite different. You can see these other Neorickettsia species, the salmon poisoning, these actually are completely different Neorickettsia. This is Neorickettsia ristisi. You can see they are very different. And these are also horses from different states, Pennsylvania, Illinois, etc. If I put another phylogenetic tree of Neorickettsia ristisi as well, I just want to highlight that there are many different strains that Ashley already mentioned. So the strains that you have in Northern California, the strain that you have in, Eastern United States, or the strain that you have from Ontario or from other parts of Canada, they will be very different. So there are a lot of genetic variability and probably a lot of, antigenic variability amongst these strains. So this is, this bacteria is called Neorickettsia finlensis, and that is due to the fact that Dr. Ricky Hisa isolated this isolate 081 from Finley, Ohio, and that's the birthplace of Dr. Ricketts, which is, described the Rickettsialis bacteria for the first time. So for her has a lot of meaning, and again, that's what the scientific name is gonna stand as Neorickettsia finlensis. Now, this bacteria was isolated from the blood of 2 horses with clinical disease compatible, Potomac Horse Fever, Ontario fever, anorexia, depression, or lethargy, diarrhea. And again, this is 2016, 2017. And they do cross-react with ristisi, so that's important to highlight. And these ristisi and finlensis, they only can grow in cell lines, and usually they use these murine macrophage cell lines for the culture. So in order to convince the reviewers to publish this paper, they wanted to see an experimental study to fulfill cost postulates. And so 2 ponies were challenged. One pony got very sick and developed clinical signs consistent with Potomac horse fever. The bacteria that was inoculated was re-isolated, and the molecular testing showed that it's the same isolate. So that confirms fulfill the postulates. And the second pony also got sick, but to a minor degree. You can see the clinical signs. And some of them, they were fairly severe, the ones that might, which probably replicates what happened in the natural world. Next slide, please. So this is the 10% of why not. And Ashley, is that you? Your turn.
I'm muted.
You're muted, yeah.
I'm muted. So we're learning about all of these different bacteria and where they are. And I wanted to put this slide in to remind us, one, why we're all here together to talk, but also how important it is for surveillance from our local veterinarians. So Potomac horse fever is not a notifiable disease. It's not a reportable disease. It likely will never be, since it's not a contagious disease. And so it really comes down to our local practitioners participating in surveillance. And so with CAS at the moment, most of our information that comes through are on those reportable and notifiable diseases, but we do have a very close relationship with the Equine Disease Communication Center, which is an endeavor that grew out of the AAP, as most of you know. And practitioners, if you have a positive laboratory confirmed case, can fill out the online JOT form that they have to do a report on Potomac horse fever. And not only does this help people and other veterinarians know that it's in the area, and especially when we're looking at different times of the year, we were still reporting them, as we said, this one's from September, but into October last year. It keeps them on our minds and allows others to keep it on their differential list. So very important in my mind that we continue to report these, so that we, one, have an idea of where things are happening, and two, to keep in mind that these are under current conditions. So to go in a little bit on our goals of our diarrhea patients here, just as all of them, our goals to reestablish peripheral perfusion, replacing our fluid and electrolyte deficits, combating systemic inflammation, trying to reduce that inflammation that's occurring locally within the intestines, promoting the repair of the mucosa within the intestines, and then getting them back to that normal intestinal flora. And I always kind of follow that slide where we talk about those basics with a reminder to check electrolytes. Because Potomac horse fever can be a bit insidious and have a bit more chronicity to it before people seek help, you can be fairly chronic and have fairly significant electrolyte changes in these guys. And bolusing a whole bunch of fluids to those horses, I've seen on multiple occasions where we just want to get them rehydrated and correct that hypovolemia, but their chloride and their sodium are so low that they aren't able to handle it. And we have that kind of brain volume issue associated with the rapid changing in electrolytes. So it is one of those cases of history and getting the chronicity of those cases as best as possible. And if it is anywhere in that kind of couple days range, thinking about doing your electrolytes before starting your fluid therapy, because it can be quite dangerous for us when they go neurologic, which I've seen a couple times, unfortunately. Antimicrobial use, we've said multiple times that this is one of those diarrhea conditions that does have a nice treatment option for it. And these are our tetracycline-like drugs. Oxytetracycline tends to be the mainstay here, and there is a wide range of reported concentrations or dosages that are used, and from everything from once a day to twice a day. Most of the literature indicates that once a day is sufficient. However, in different areas, it seems, and right where I am, we seem to have better response when we're going twice a day with this. And we don't know whether that has to do with different strains. We got a lot of negative cases on PCRs, and then we thought we would try and treat anyways. Those are things that we're looking into because we think we may have these other species with us, but we don't know how the new strains and new species respond to the different concentrations here. In general, we say 3 to 5 days. Some people say 2 days past resolution. 5 days seems to be a common timeline for it. And it is important to have those discussions on the contraindications and complications with oxytetracycline, especially in an extremely dehydrated horse. And important that it does bind that calcium. So if you give it quite quickly, some horses will go down as that calcium binds either skeletal or cardiac muscle calcium and cause issues there. I tend to give it in a 1 liter bag of saline because the lactated ringers would have calcium in it, and it'll precipitate and look cloudy in there. But that just slows down the administration slightly to make sure that we don't have an issue. Most cases, and especially early cases, respond quite quickly. So those early ones, you may see a change around right within the 12 hours. I know a lot of practitioners look at the 24 to 36 hours after the treatment has been initiated. If it turns around, then that's their diagnostic way of looking at it, as opposed to testing. And we do see that a fair amount. It does not interfere with the antibody production, but as I mentioned before, it does interfere with the testing afterwards. So make sure that you have your sample collected before. There are also oral dosing with doxycycline for those cases that IV is with the oxytetracycline is not possible, although in most cases it is more expensive. I find that doing the IV first is more efficacious, but that's just anecdotal from my side of things. There is quite a bit on preventing laminitis, since this is a big part of it. And we do know that cryotherapy, there are a couple studies that have looked at cryotherapy in colitis, but also specifically with Potomac Horse Fever, and decreasing the mortality rate due to laminitis. In this specific study, they found about 25% or 21% of cases got laminitis, and when they had ice boots after the occurrence of colitis, it actually had only 10% of them having occurred laminitis. And so they had an actual statistical odds ratio improvement for these guys. So icing, there's numerous new ways. We've actually moved from using the boots to we've been able to make very cost-effective boots that are very similar to these ones using dry bags from camping, which has been extremely less expensive, and they get destroyed less often than these fancy ones. Memo, you're up.
Thank you again. I guess that this is a fairly important part, and see whether we can do any from the preventive side. And there is a vaccine that has been around for a very long time. So there are some publications where they promote or they highlight since we think that is an oral ingestion of form of infection, to perhaps minimize exposure to some of these. The reality is that we don't really know how the horses get, and Alice explained that, perhaps they are eating some of these dead flies, or they are drinking water, let's say with Cercaria, which has the bacteria. And I was in a talk with Dr. Madigan where he said that, some of these horses were actually getting infected. They were in the barn, they had no access to the pastures or close to the creeks, or that might be some of these some of these insects, I'm sorry. So they actually thought that they left the lights on at night, and the flies were attracted by the light. They were dropping on the feeding crates, etc. And that's how the horses, or the food that they concentrate, and that was where getting infected. So common sense practice from turning off the lights, or it's easy for us to say, oh, don't graze the horse near a creek or river, but if that's the pasture, that's the pasture. So, and we don't know how that some horses in a big herd of horses, you have a single case. Actually, although outbreaks are reported, they are not that very common. So we do have outbreaks. We do have several cases from the same farm, but typically it's a single case. And even though there are many horses in the same farm, so it's difficult to stress some of these preventive measures. But here we put some of those just to be aware of, and as I mentioned, common sense. Now, I know we already got some questions about this, and we, the vaccine, obviously we reach for something that we, just like now, we're in the middle of pandemic, and we want to are you vaccinated? Yes, I'm vaccinated, so you're fine. So, we're hoping to be protective against this, and obviously we want to protect our horses. So this first vaccine that is with this Maryland strain, some of the original study by Dr. Ristic, when he did the experimental study, it was very effective. And some other studies, even looking at many horses, they claim that perhaps, you know, the number of cases in the following year was less. But we also know there's a lot of great deal of seasonality or you know, variation from year to year or season to season about the number of cases. And lastly, some of the you know, some of the later reports when we see many of the clinical cases, a lot of the cases where we isolated the bacteria or we have clinical cases, they were vaccinated. So I just gonna leave it like that. You know, you see the guidelines about, you know, giving the 2 doses and then first vaccine and a booster, and then doing the annual vaccination or revaccinated, especially in endemic areas. The reality is that we, you know, we don't know how protective it is or the effectiveness. You know, I cannot really speak with any authority about this. The vaccine is a killed vaccine, so it does cause a weak immune response. And we know now, and one of the biggest questions is like, is this related to the different strains, or the strain from Northern California or the strain from Maryland, which is very different from the strain from Ontario or California, etc.? Is it going to be effective? The answer is we don't know. Probably it does induce some degree of immunity, but we don't know how protective it is. The reality is that we do get cases from vaccinated horses. Vaccinated horses are presented to the clinic, and we isolate the bacteria from horses fully vaccinated. So there are lots to learn from research in the future about, you know, so whether the cross protection or maybe a multi-strain vaccine, or, you know, a vaccine that it will be a common antigen that can induce more long-lasting and more wide spectrum response will be much wanted. And obviously now with the new species, we need to know how much cross-reactivity there is and whether or not new vaccine may need to have both species. And this is an interesting little paper that Dr. Howard Mackenzie from Virginia published just a couple of years ago. And it was, for me, simple, but really important or really applicable to all of us in the field. You see, he looked at whether it was, you know, if you give a monovalent vaccine, just the Potomac vaccine, or a multivalent vaccine, there was going to be a difference. And the fact that was both vaccines were poor, only about 1/3 of the vaccinated horses show an immune response or a seroconversion. And then it was even weaker if the vaccine was a multivalent versus a monovalent vaccine. So, and then this difference was not significant by 3 months of vaccination, basically. But you can see the numbers over there. And this is using 400, you know, titer 1 and 400s as a understand that is seroconversion. Next slide, please. So we do have, we've been working this for many years, and many of you, I've been looking at who is in there, and I'm very happy to see so many familiar names. Dr. Bear and I, we've been working this for a very long time. We have, you know, I found some pictures the other day that we were looking for mayflies in 2005. So, and we've had this great partnership with Ohio. And so we do have ongoing research that we would like to present, and just to show you, because basically we have lots to learn. And now we have a partnership with Ashley and the group in Alberta. So we have some studies on the go. I just want to mention, I'm just going to go back a little bit to mention that, for example, up until right now, we have 16 isolates from Ontario, 2 of which are a new species of Rickettsia, which is, you know, for us, it's a massive finding. And we have also some great people helping us in other provinces. We can mention that last year we have 4 positive isolates from Alberta. So I know we have isolates from Alberta, and then we have 3 isolates from Quebec. So There is a practitioner in Quebec, we sent a sample, so we asked for 2 of his cases, Dr. Waybridge, thank you very much. And also Dr. Leclerc from University of Montreal in Shanghai. One of her cases we managed to culture, Dr. Ricky Hiss, and so we have a big collection of isolates to learn from and to type and do some molecular testing, but we have some ongoing research at the moment. And maybe Ashley can talk for a little bit about the project in Alberta that is about to take off.
Yeah, so we are just starting this in the next month or so to do a seroprevalence study, species identification, as well as looking at previous postmortem studies. So on the next slide, I'll tell you what we're in a little bit more detail. And Memo, you're doing some environmental and looking at the life cycle of the new species, as well as more provinces, is my understanding, correct?
Yeah, and perhaps now with all these people in the audience, if you are coming from different provinces, we probably the Canadian story is bigger, and there are many regions in this country that are favorable for this disease, and I know that many of you out there already know that there is out there. I remember many years ago, I went to Eastern Ontario and talking to practitioners, and they say, well, the testing is negative, but we know that is that, and we just treat them, they get better. And they were totally right. But now we have at least data to confirm that. And so we are very interested on collecting samples from all different provinces, not only to do, like, for example, molecular testing, but also isolation. So we usually get blood shipped to us, and then we send that for PCR and for culture. So that's something that we can further expand. But I just want to say right away that many of you that are interested, our contact information is at the end of this presentation, and you can contact us to see if you want to participate or help with some of this. We are not very needy. We also usually need just like some samples. I was in a phone conversation today with a practitioner, with Dr. Cooper, actually in Alberta, and she thinks that they're already seeing cases right now. So the season may already started in some of these places. And as I mentioned in the beginning of this presentation, the first case last year was at the end of May. So it's getting hot. Today was 26 degrees in Guelph, and it's still nice and sunny. So we expect that some of these cases are beginning to show up fairly soon. Go ahead, Ashley.
Yeah, we're doing so Sarah Toner, who's just completed her second year here at UCVM, is working with us this summer, and we're going to be doing a seroprevalence study. So we will be reaching out to Alberta practitioners, and if any of you are here, we're going to be looking to get practitioners from as much of the regions of our large province as possible to collect serum from healthy animals so that we can look at the seroprevalence. And then we are also going to be doing a prospective study for identification of species and strains. So we're looking to recruit another 10 veterinarians who have previously had Potomac Horse Fever cases that would be willing to collect blood samples prior to any treatment and fecal samples, and provide a limited case data for us. And then along with Memo and the lab in Ohio, we are going to be looking for culture and as well as PCR testing on these. And we've had a lot of cases out here in Alberta, as Memo said, that they respond and they seem to do well, but they test negative, and we're highly suspicious that we do have new strains or the new species with us. So here is our information, and I believe that we are easily Googleable as well. We also wanted to thank all of our team members that have been working with us on this for our respective provinces. And Also, we wanted to thank the funders and all of the practitioners. So we have funding through our clinical research fund at the University of Calgary, and Memo has research funds from the Ohio State Equine Guelph and the Owen Network.
Yeah, I just want to stress the fact that this could be done with so many people helping. In this case, as I mentioned here in Guelph, all people at OVC, but particularly Dr. Bear, and lately Allison has been involved in some of these ON projects, and we could have done many of these ideas without the practitioners, that they have been so keen and so helpful in sending the sample. We get it is a little bit logistically important to get the samples in good shape, so they have to be shipped overnight and things like that. So we have samples sent from Quebec, from Alberta, from everywhere in Ontario, and we are extremely grateful to all these people that send these samples. I mentioned I will have 2 or 3 slides on practitioners that have been helping, and anonymously I want to say thank you to all of you. And I'm very grateful for your contribution, that I think I'm making a difference in this. And I can just say that, we are in the middle of doing some of the molecular testing for the isolates from Quebec and from Alberta and Ontario, but very likely we're gonna have, a good idea of which species are present on all different places. And hopefully we'll have this information out this summer. I also want to thank the organizers for inviting us and having us tonight. I hope that this was entertaining, and I want to say shout a big hi to many of the practitioners that I recognize in the chat, and I miss them all. And thank you for listening.
So, Allison, do we have some questions that have come in?
We do. Well, first I want to thank both Dr. Arroyo and Dr. Whitehead for a fabulous presentation. I think that was just a wealth of information, and it's exciting to see the research that's developing from it. We do have some questions. So I think the first one is for Dr. Arroyo. You mentioned the experimental infection with Neorickettsia finlayensis. Do practicing veterinarians, though, notice any different signs or degree of severity and disease caused by Neorickettsia finlayensis compared to Rickettsia? And then can we use the same diagnostic tests to find this new strain, and is it treated the same?
Great question. I love that question, especially the first part, because I have exactly the same questions. There are a few things that we don't know. So far, these finlayensis and Rickettsia have been isolated with horses with typical signs of Potomac, if you wish. So at this stage, we do not have any data on severity of disease or difference in whether one species does, affects the disease severity or the other. We don't also have any data on whether co-infection with the 2 species may exist, and maybe that will explain some of these things. And then what was in the middle?
Diagnostics, is it diagnosis?
Yes, yeah, that's super important. So basically the current PCR testing does not distinguish between the 2 species. And then we haven't said the Ohio lab is working in a real-time PCR to test, and it's pretty much done. I said we're waiting for this data to come out to say a qPCR for Rickettsia, qPCR for finlayensis, and people down the road, all these smart people in the last may develop like a multiplex PCR. So far, the way to distinguish this is through some tests on some particular genes that is not very practical in diagnostic lab. So once the bacteria is cultured, they has to run these genes that basically separate the different isolated strains or species. And so I think we hope that this summer we will have some diagnostic tests geared towards finlayensis that can distinguish the 2. But so far, we don't have a commercial diagnostics test for this bacteria. In order to do it, it will still have to go through nested PCR, which is very time consuming. The treatment, we believe, is the same, and they respond well to the same antibiotic. Having said that, we have noticed here, and maybe we don't know the reason, but
Hey guys.
Yeah. Dr. Bear and I noticed that some cases we have some non-responders, and we haven't collected enough data to find out if these cases are complicated with something else, you know, or you know, we don't respond, but we have some cases that they are treated and they don't respond as well as you would expect with this oxytetracycline. Thank you, Dr. Bell, for your comment.
All right, the next question is kind of on the same, dealing with risk factors. Since bats are an important part of the Neorickettsia life cycle, do horses with Potomac horse fever cluster around locations of bat caves? Is it a risk factor, and is that being researched? And that could be for either of you.
Since I just found a bat on my house window last night, and I now live beside a creek, I'm hoping not. To my knowledge, there hasn't been almost any research other than knowing that it's the definitive host, that there would be any relationship with it. It still has to have those intermediate hosts, which would likely be the more prominent feature to being infected. Have you seen anything else, Nemo? I haven't.
Yeah, the short answer is there's no data or any indication to suggest that, you know, areas with high population of bats would be a higher risk. As Ashley mentioned, the bats can travel great distance at night, and they have to defecate and release the parasite, which is parasite with the bacteria. So the bacteria is a parasite of a parasite that needs to go in the water and go through the life cycle in the water, which is transmitted vertically through these you know, intermediate stages of the parasite and infect the flies and so on. And so it's, you know, we think that perhaps the infection route or the infection component of the disease has to do more with intermediate hosts, as you just said, rather than the definitive host. But obviously those elements are all needed in order to occur. Thank you, great question.
Okay, the next question. Is there any data on co-infections with Neorickettsia species with other organisms such as Salmonella or C. difficile? Go to Ashley first, if you know.
I don't think there's any actual studies looking at co-infection from the beginning, and we tend not to retest to find out if we have those secondary pathogens coming in and becoming positive later on. Most of the stuff that we've seen in co-infections in diarrhea has been surrounding foals, where we've looked at things like coronavirus and I guess, less pathogenic perfringents and those kinds of things as being co-infections. But in adults, we haven't had any significant research come out to say that co-infection is a big cause of it. But as I said, I think we're more, if we were testing later on, we may see co-infections as a secondary sequelae of it.
Yeah, there is a paper just came out from Pennsylvania, and they did look at, it's a fair sized paper where they have many cases, Salmonella, so Potomacs, coronavirus, and things like that. And actually, the co-infection rate was extremely low. So we don't have a lot of data, and we might have some here coming out. One of my colleagues, Dr. Gomez, is doing some data mining, and there's a paper coming out soon, and we will have some of that information. But Ashley rightly so mentioned that we tend to stop once we find the diagnosis, or at least we think that's it, you know, if it's Potomac, and then perhaps that's the wrong approach. But I think there's something that probably needs a little bit more investigation in the future. It's a good, and we wonder sometimes, as I mentioned, some of those not responsive, if they go on to have something else as well, but we don't know. Thank you.
Thanks. Okay, the next question is a treatment question. So with regular acting injectable oxytetracycline unavailable, Does the brand, formulation, or carrier of the long-acting oxytetracycline matter from a safety or adverse event perspective? Go to Ashley.
Ashley's for you.
So we use the long-acting tetracycline mostly. Sorry, I was trying to follow my instructions of stopping screen share here. So we use the long-acting LA200 usually for treatment. To my knowledge, there is no difference in the dosage or the efficacy of them. With them, we continue to do the same dosing regime with them as well. I would say the biggest thing, you know, there was a lot of discussion, I remember, while I was going through my residency in terms of the color of the oxytetracycline, whether it was a caramel or a dark color, which I recently read the color isn't as big of a deal as we once thought it was, with the bit of the oxidation on it. But to my knowledge, there's we're looking at that oxytetracycline as the drug itself.
Yeah, and we use the 6.6 mg per kg. Again, we don't see any difference either. We just, in this case, give it diluted. And then, you know, there is actually a very nice study from Dr. Dolling from the Western College, and she showed that the once a day, it should last enough and be good enough. And Dr. Bear, for example, is a great believer that we use it once a day, and I think that's what we use it. I usually more of a chicken, depends on the case, and use it twice a day. But in general, we see a great response, you know, with either dosage and or a protocol within 48 hours.
Great. And so the second question is kind of along the lines, so it's of antimicrobial use. So the question is, I have heard anecdotes of using one dose for early cases in endemic areas in the USA, but would this be suspected to contribute to antimicrobial resistance faster than 3 days for those quickly responding cases? Ashley.
I personally would go for the 3 days. I think that, you know, even if you see that response, you still have a significant amount of probably bacteria that is within the enterocytes that you haven't gotten with that first dose. And so I would continue on even if I see a very quick response to it. I think, you know, I don't think that we need to go to excessive lengths the other way of treating for a long time after the recovery of the horse. But I personally have not ever done a single dose or think that I think you're just going to miss too much because it is that intracellular organism there.
Just to add there, Stephanie, there are serious studies on, you know, resistance or things like that about this, but I would agree that, you know, I don't think it's a good practice just to give it one shot and forget about it. You know, probably needs to be completed the treatment if it's confirmed. And the studies about antimicrobial resistance on these bugs they're very difficult because it's an intracellular bacteria, so you have to, you know, do it that way. And there's some stuff by Dr. Rikihisa, and you know, the oxytocin is still very effective. Doxy seems to be also very effective, but some people don't like to use it because it's oral. But I think, you know, being absorbed in the small intestine, it should work. And I actually have great desire to try it to see, especially when we were like in a shortage of oxytetracycline. But anyway, I actually haven't used it myself yet, but the in vitro studies were very encouraging. And again, I will agree that I don't know what that can come from by one dose, but yeah, I'm not too sure. I think that we should complete the treatment.
I have used the doxycycline, especially in cases that referral is not an option, or that, you know, repeated injections on farm are not going to be an option. And so those are ones that I have used the doxycycline, and they're the milder cases for sure, because they're ones that aren't coming in for aggressive IV fluids, but I have been pleased with the response in those.
Great to hear.
Great. Are there any other questions? So for those people who haven't submitted in the chat, you could unmute yourself if that's easier, if you have a question you'd like to ask.
Allison, I just had one come in on the chat.
Sure.
And it's, how do you balance the teratogenic effects of tetracycline and the risk of abortion? I find it easy in confirmed cases, but a hard call in suspected but unconfirmed cases. So in the pregnant mare.
Well, I will start by saying that great observation. We don't see these pregnant mares as you see it in the field, and I guess that it's a risk, I suppose, that that you might have to run. I would be very surprised with 3 days of treatment that this drug is going to go and affect the fetus so badly. And also probably you need to consider the stage of gestation. Obviously that will, what organogenesis is happening and things like that. But if you're going to lose the mare, or it's going to develop laminitis or something like that, it's kind of like a cost benefit, I guess, that you will treat and hope that that the mare recovers, and perhaps even when the mare recovers, you might still lose that fetus due to infection that that fetus basically, if you wished, wasn't treated or still remain infected, and it's going to have an abortion down the road, as is being shown already in some of these cases, that these mare were treated and yet they still had an abortion down the road.
And my understanding with the human effects, I mean, we can get the discolored teeth if it's in the later gestation given, and more embryo at the very early stages where it can cause issues to the embryo. None of those have ever been reported in the horse, to my knowledge. And I can't say that I've ever seen a horse with discolored teeth, but that's also, maybe we're not looking for the fetus for the foals for those. In my opinion, it's, as you say, if we have a confirmed case, then it's a pretty, I'm going to go with my best option for saving that horse and preventing further complications, laminitis and such. If it's an unconfirmed case, I think it's having the discussion with the owner on the risk benefits in that case is really going to be the big discussion that I'm going to have, so that I have that informed consent on it.
Great. Any other questions? I think before we leave, because as we've seen in this presentation, that surveillance is really important, and particularly for putting Potomac on one's differential list. Knowing when the season starts and when the season ends. So I'm going to ask Teresa if she can just let vets know how they could go about reporting Potomac Horse Fever cases through CAS.
Sure, thanks for that. So if you go to the CAS website, which is www.cahss.ca, there is a disease alerts page under the CAS tools. And if you go there, you can see that there are some disease alerts posted already for, not for PHF, but for other equine diseases. In fact, our equine network is the leader in posting diseases so far. We've just launched this, but there is a form to report on there, and you can fill that out. So if we receive that report, we'll validate it, and then we'll go ahead and post that alert on our website. And we'll also cross-post to EDCC if we receive an alert and we think it's of value to them. So it'll hit both of those places at the same time. And I think the other is also true, that if EDCC receives an alert, we will try to capture that and post it if it's a Canadian case. Our form is a little bit shorter. Their form contains a little bit more detail, so you can decide sort of based on your time and level of detail which you want to use.
Great, and we did have one question slip in here. It's similar to the pregnant mare question. So how to use tetracycline for Potomac horse fever in horses with acute kidney injury due to marked dehydration and sepsis. Any recommendations? Ashley.
I think this goes back to starting with your fluid therapy. I mean, the time that it's going to get a bit more hydration and perfusion in that horse is not going to be the end of the world between getting that that oxytetracycline in. Once they are hydrated, then we should be at a little bit safer with it, although when they do have, then when they actually have damage to their kidneys, it could at any time, even if they are hydrated, contribute to it further. And so with those cases, again, it ends up being a bit of a discussion with the owner. I mean, even oxytetracycline, we know that it's one of those drugs that can cause colitis in horses and potentially could make that worse as well. I tend to be a little bit more on continue to be in that range that we have for the MICs that are demonstrated in that Dowling paper, but try and not go to the high end of the dosage range that's there, even if it is a very severe case, so that I'm not giving an extra amount, and then making sure that I'm not providing NSAIDs at the same time. Try and do alternative forms of pain management like butorphanol or intramuscularly or something, so that I'm not adding another nephrotoxic drug on top of it. But really the hydration to me is, I'd rather wait a little bit before giving antibiotics in those cases. Memo, do you have any other words of wisdom?
No, it's I think restoring cardiovascular perfusion and getting the kidneys to go back to that is typically we think that these kidneys are actually pre-renal azotemia due to severe dehydration. And I think you made a point earlier where we have, when we look at the cases and we put this data in the paper that's coming next month, we have, for example, we have cases that are referred between 1 to 10 days or whatever, 7 days. Some cases are being sick for a number of days. So and the thing is that some of them just develop lethargy or inappetency, so they wait and and rightly so, I guess they don't see any diarrhea, for example. So there is a range of these cases. So I think that addressing supportive care before and taking that in consideration is the way to go. But Sophia, we can talk more about that.
All right, last call for any questions. And hearing none, I would again like to thank our speakers for a fantastic presentation. Don't forget to report your Potomac Horse Fever cases if you see them. They'll give us an idea of where they're occurring and when they're occurring. On the CAS page, perhaps we'll reiterate the contacts for Dr. Arroyo and Dr. Whitehead for their research in terms of getting samples sent to them. And I think we'll continue on this journey for quite a while as we learn more about this disease. So again, thank you everyone for coming. It's been a wonderful evening.
Thank you so much, everyone, for this evening, and I appreciate listening. Any comments and anything you want to share with us, just email us. And I'm very much thank you, the organizers, for inviting us. Thank you so much.
Thank you, everybody.